Hello and welcome back to Doc Talk, focusing on the clinical utility of angiogenesis inhibitors in metastatic colorectal cancer. So in this session, we're just going to have a kind of a roundtable discussion and talk about a number of topics and clinical trials and novel agents that are coming up and where things are headed in this very important disease that is so common in this country. So let me pick on Scott first. So you talked a little bit about Brivanib and the fact that it's a VEGFR and FGFR inhibitor, and you mentioned in the trial when it was combined with cetuximab that there was significant toxicity. Is it your impression that this toxicity was really related to the Brivanib, or was cetuximab just not a very good partner for an FGFR VEGFR inhibitor?
That's a good question, and this is an agent that has a wide spectrum of targets, and while FGFR and the VEGF and the FGF pathways are the key ones that are being inhibited, we think, with that. There are other targets as well. I think it leads to a bigger point, and I think one message that we've seen across multiple studies with multiple different VEGF and VEGFR class tyrosine kinase inhibitors is that these are difficult drugs to administer at full doses in combinations with chemotherapy. And I think that we have to recognize that as we do these studies, that we add additional agents on top of what can be regimens that are already a little difficult to tolerate with metastatic disease, that sometimes we can push these toxicities beyond what our patients can tolerate. So I would say it's probably not a class effect of the FGF as much as probably a general theme that we're going to continue to see as we develop these angiogenesis inhibitors.
So I know the other really vascular tumor, renal cell carcinoma, I mean, they're looking at nintedanib and dovitinib, FGFR inhibitors. Is there something about colorectal cancer that makes patients more susceptible to the toxicity, or do you think it was just the combination, and should maybe the trials be done as single agents?
Well, I think we can look at where we've had success with tyrosine kinase inhibitors. I mean, we've had, by some estimates, over 12,000 patients treated under clinical trials with tyrosine kinase inhibitors that target VEGF. And it was only when we got to the point of doing a study as a single agent combined with best supportive care that we really uncovered the signal, uncovered the clear activity. So I think a lot of it is that combination. And as the example that you mentioned in renal cell, a lot of that is single agent activity. And so perhaps this is a failure of the drug development strategies in metastatic colorectal cancer and less a reflection of different toxicity profiles across tumor types.
Because anti-EGFR drugs are difficult to take as it is with all the rash and the other effects. And well, I guess we'll just have to wait and see what the trials show. So Jolene, let me ask you a little bit about ramucirumab. You talked about it in your initial presentation. I mean, this monoclonal antibody, developed originally by ImClone, I guess, is targeting VEGFR2, which I guess is the main driver for angiogenesis on the endothelial cell. This drug has been around for almost 10 years now. It's taken an awful long time for it to move forward. We heard at ASCO GI about the data in gastric cancer that seems very encouraging. You know, what is going on with this agent in colorectal cancer, and are there clinical trials for which our community oncologists can refer patients?
Yeah, and so in my earlier talk, we talked about the ECOG study, which was randomizing patients to receive the chemotherapy plus ramucirumab plus cetuximab. And so that would be a good clinical trial to enroll patients in. I think the reason why it's taken so long to develop ramucirumab probably is. It's probably tough to compete with bevacizumab. It's been incredibly successful. It had rapid uptake in the community. It's very well tolerated with very low side effect profile, and you can maintain patients on bevacizumab for quite a while. So I think it's probably been slower to develop in colorectal cancer because of the success of bevacizumab.
So this agent targets the VEGFR receptor, similar to the way cetuximab latches on to the extracellular portion. Are there any thoughts, and I'll ask this to all of you, of combining an agent like ramucirumab with a VEGFR tyrosine kinase inhibitor and doing more of a total vertical blockade?
I mean, we actually recently submitted a paper to a very respected journal, I hope, where we detailed our experiences of combining sorafenib with bevacizumab in a salvage therapy setting, which when you adjust doses and you really lower the dose, especially of the kinase inhibitor, you can get away with the reasonable toxicity, and the efficacy in the setting, which was not a randomized comparison, but it was 80 plus patients in a community setting, was quite remarkable in terms of, and actually comparable to what we see with regorafenib at this point in time, which is no surprise because sorafenib is a very similar molecule. And Jolene had a trial, which in a phase 1 setting actually, which combined FOLFIRI bevacizumab with sorafenib as a second or third line setting, which was actually quite successful.
Yeah, so as Axel mentioned, combined FOLFIRI, bevacizumab, and sorafenib. And this could be in any, it was intended for second-line colorectal cancer patients, but it could have been in people that had had irinotecan previously that may still be a candidate for it. And we did see, we used reduced doses of the sorafenib as opposed to full doses that were used for hepatocellular carcinoma. And we did see that it can safely be combined with bevacizumab and chemotherapy when used at reduced doses. And I do have several patients that have been on the trial for well over a year with stable disease and doing well. So the company does not want to develop sorafenib further in colorectal cancer. I think the trial is a proof of concept that bevacizumab or a large molecule inhibitor can be safely combined with a small molecule inhibitor and with chemotherapy. We just need to be very smart about the doses that we're using.
And how to do it. Very good. Well, Scott, let me ask you, Axel said something earlier about biomarkers. I mean, we've really been looking hard to try to find a predictive biomarker for anti-angiogenic therapies. I mean, everybody has looked at VEGF levels, I guess, and perhaps VEGFR2 expression and things like that. Are we getting any closer to identifying which patients are more likely to benefit from anti-angiogenic therapy?
Yeah, and this has been an area where there's been a lot of work, and I think it really shows the difficulties of developing predictive biomarkers. KRAS is, I think, going to increasingly be recognized as the exception instead of the rule, recognizing the complete clarity that we saw in as KRAS as a predictive biomarker for EGFR inhibition. The reality, when we're looking at targeting the endothelial cell, is harder. We're targeting a cell that does not, by definition, have mutations or derangements. It's a normal cell in the body, and we're looking at variations and gradations of many different receptors and ligands in that environment. So we're not dealing with a clear black or white, mutated or not, but instead variations of a very complex environment. And so I think the difficulties are going to be moving forward, and the reason that we don't have a biomarker yet, I think, is part of this these shades of gray of benefit as opposed to a more black and white scenario.
Right. So you guys are really some of the first community in oncology to really target the microenvironment. Everyone else is talking about targeting the microenvironment, but the anti-angiogenic agents really do target the microenvironment. And maybe maybe we just need to be happy with what we've accomplished there, but it would be great to have a predictive marker and find out why some patients do and some patients don't benefit. But it's probably the interaction of the biology of the malignant cell with the microenvironment. All right, anything we haven't covered?
I think we're pretty comprehensive.
Very good. All right. Well, thank you all. This has been really interesting. I've learned a lot, which is the purpose of these programs. So it's been a lot of fun. I hope you have all enjoyed it and learned as much as I did from this doc talk on the clinical utility of angiogenesis inhibitors in metastatic colorectal cancer. Thanks so much for staying with us.